Good morning, and welcome to Medicine Grand Rounds. It's really my pleasure today to introduce Dr. Jeff Wiese, who is here as part of the Chair's Distinguished Speakers Series, or the Dream Speakers Series. Jess Tischentorf identified Dr. Wiese, and we were very fortunate to convince him to come and be a visiting professor here, spend time with us, and provide grand rounds. He's a graduate of Drake University, and then went to Johns Hopkins School of Medicine, and then out to the West Coast to the University of California, San Francisco, where he was a medical resident, chief resident, and took a medical education fellowship. He went on to Tulane, where he is currently director of the Internal Medicine Program, chief of medicine, charity and university hospitals, and associate chair of medicine, and senior associate dean of graduate education, and Tulane professor of medicine with tenure. He lists over 39 medical peer-reviewed publications, focusing on medical education and high-value care most recently. He's authored 6 books, has 17 book chapters, and has been supported in his work by HRSA and the Robert Wood Johnson and other organizations. He's a very good citizen, both locally and nationally. He serves on the Tulane University Hospital Board of Directors. He's chair of the Graduate Medical Education Committee and has served as the secretary of the University Senate. Nationally, he's had many service opportunities and posts, including chair of the American Board of Internal Medicine, currently for the Internal Medicine Board. He serves on the Board of Regents for the American College of Physicians. He's past president of the Society of Hospital Medicine, served on the Board of Directors of the Association of Subspecialty Professors, as well as the Board of Directors of the Association of Program Directors in Internal Medicine. I counted 31 teaching awards, and I've never seen an asterisk that said the individual had to stop accepting intramural teaching awards back 9 years ago. So imagine what number that would be at now otherwise. Among his many honors and awards, he received the Society of General Internal Medicine Mentorship Award, the Leonard Tow Humanism Award, the Alpha Omega Alpha, Robert J. Glaser Distinguished Teacher Award from the AAMC, the Parker Palmer Courage to Teach Award from the ACGME, the Society of Hospital Medicine Excellence in Teaching Award, and going back a little bit further, he was a USA Today Academic All-American. He was a triple-year letterman for the varsity football team at Drake, and he is a member of the Oklahoma High School Football Hall of Fame. I think a first among speakers, much less dream speakers. Dr. Wiese has provided presentations nationally and internationally. I literally counted 258, as well as 90 visiting professorships. He commented to me that he's never been a dream speaker before, so the pressure is on for this lecture. And it's really my pleasure to introduce him as he provides grand rounds entitled "It's Not What You Think: Changing Culture on the Wards." Welcome.
Thank you. Well, first lesson, be careful what you put on your CV. I'm going to have to take some of that off. Well, a pleasure to be here, and to help balance that introduction, I'll start with a story. You in the mood for a story? All right. So the story goes something like this. In 2000, I left UCSF and came to Tulane to be the chief of medicine at Charity Hospital, and almost simultaneous with that, to be the program director. And I was going to change Tulane. And I got busy, wrote a whole new curriculum for the residency program, for the faculty, designed all new policies and procedures, including one that specified that heretofore all patients would be discharged by 11 a.m. Because I think we all share my CEO's view that every medicine bed's a wasted ortho bed, right? So just get them on out. Indeed. All new policies, procedures, all new curriculum. And then you fast forward 4 years, and guess what we found? Absolutely nothing changed. Everybody was smarter. Everybody was more informed on what we should be doing. It's just that nobody was doing it. And you hit one of those failure points, I'll tell you, you look into the abyss, and the abyss looks into you, and you come to a couple life realizations. First, that knowledge, skills, and attitudes is what defines competency, right? But when it comes to performance, it's the attitudes that carry the gravity. Knowing what we should be doing is different than actually doing it. Case in point, I don't need a module to tell me how to wash my hands. That's not the reason I'm not washing my hands, right? And the second thing that you could summarize out of that is that at the end of it all, it's not as much about what we think, it's about how we think. And the second realization that you follow from that is that policies and procedures, yeah, they work in governing behavior. They work when somebody's watching. A speed limit works for me when I see the highway patrolman there, right? But what governs behavior when no one's watching is not the policy and the procedure. It's the culture. Those shared roles, goals, expectations, and beliefs. And now you look at it and you say, oh my God, Wiese, but isn't culture like ambient air, right? I mean, can we change that? Isn't that like pollen count and it's just going to be what it's going to be? Well, I'm going to submit to you that culture can be changed. And if you're willing to go on that journey with me, then I'll try to make my best case. So a few meta lessons as we go through. There'll be 5. Lesson number 1. No one changes anyone's mind. The only person to change man's mind is that person. Goes for women too. This is an exercise in persuasion, not an exercise in debate. Well for politicians in D.C. if they could figure that out. Meta lesson number 2 is that if you want to change somebody's mind, you don't start with, hey, this is the way that I want you to think. You start with, hey, what's causing them to think that way? And then you work backwards from there. Meta lesson number 3. That the things that change people's minds are not the big things. It's the small things, the habits, right? The things that are frequent, accessible, tangible. As Aristotle put it, we are what we repeatedly do. Excellence, then, is not an act, it's a habit. Put another way, it's easier to act your way into new beliefs than it is to believe your way into new actions. And meta lesson number 4. There are things that you say, and then there is a load of things that you communicate. And the final meta lesson, which is going to be a jagged little pill, but here it is. It's the one I learned the hard way. Either you own the culture, or the culture is going to own you. Well, all right. Let's start with breaking this down a little bit. And I'll start with chapter number 1 on culture. Expectations. How do we acquire these expectations? Well, Bandura might help us with this social learning theory. Anybody read this book? Of course not. You would have to be conscripted into a philosophy course, as I was, to read this book. But here's what it is. And I'm going to do the pathophys, if you will, the anatomy of the good student and the bad student. And listen, I get it. We're under an era of wellness, and I get it. No bad people, right? Everybody's the same in the eyes of the Lord. But what I'm talking about here is good performing students versus bad performing students. This is how a good performing student comes to be, acquiring the expectations. We take a student, then we put them in an environment, let's say the clinical wards, right? And the student sends out a pain, a behavior. And let's just say, for the sake of argument, it's a bad behavior. I'll give you an example. You in the mood for another story? Yeah? All right. So I understand you use EPIC here. Yes? Yeah, we do too. It stands for an epic number of student notes to cosign. That's what it stands for. But there was a day, my residents can't believe this, but there was a day where we had pen and paper, right? You had to write your orders, and we had BID, and you'd spend tons of curricular time on getting people to write legibly, et cetera, et cetera. Well, it happened on this day, and I was a ward attending, and I don't know what I had scheduled that afternoon, something, but a lot of meetings. So I snuck in early and saw all my patients for the team, and wrote my notes. Right? Generally, I'd wait for the team to do their notes and then write. So I wrote my notes, and the student, my third-year student, co-signed my note. Agree. It's like, All right, well, one, you didn't use the proper linking language, right? You have to have seen, examined, and discussed the patient. But more importantly, too, no, play your position. I agree. You do not agree, right? And so the student got the feedback of, okay, no, the attending agrees. The student doesn't agree. And he modified his behavior. And this goes around and around and around, right? And through all of these cycles, right, the student generates some set of expectations. What makes the student a good student is those expectations are effective. They coincide with reality. They help get things done. Yeah? Now the bad student. Same student, same bad behavior. And you would think that the student does a bad behavior and then some malevolent force like Jerry Jones here, right, comes and says, oh, keep doing it. I feel the evil within you. But it's not that. It's not an exercise in abuse. It's an exercise in neglect. Because what the student gets is no response. And so he internalizes, just trying to figure out, what's the right thing I should be doing here. Internalizes that as maybe that's okay, right? And then does it again, and again, and again. The exact same pattern. And that student, too, develops their set of expectations. But what differentiates the two is that this bad student's expectations do not coincide with reality. And then along comes you as the supervising physician, right? And you give that student feedback. That student now nested within their granuloma of expectations. And you'll know it when you hear these words. Well, nobody's ever told me that before, right? Or other code words. People are being mean to me. People don't understand me. That's the student nested in their granuloma. Now you can say, well, all right, how do you get them out of the granuloma? And that's a separate 2-hour talk. There's a way to do it. I'm going to tell you this, though. It takes a long time. Why? Because understand the psychological fear of realizing that one of those expectations that you thought was true is suddenly not true. It opens up all other expectations with the student asking, wow, what other things do I expect that aren't true, right? Gravity? Yeah, that still works, right? Should I breathe? Yep, stay with that one. But easier, right, to put up the shell and say, you know what, your expectations are not my expectations. What you can say for purposes of our discussion is simply this. The best way to beat this is to not get in that position to begin with. And so you begin with something that looks like this. Now, don't worry. Before the interns in the back, I see you. You're like, oh, I'm on a fake page on this one. All right. Don't worry. I'm not going to go through all these. So I'm going to make this. And if you're interested in these, you can find them in my book, Teaching in the Hospital, which I guess I should have declared. I do get 50 cents a copy royalties, so buy a lot of them. Graduation coming up, they make good gifts. But this is my favorite part here, so, right? The picture they chose for my book. You see a senior physician here talking to a millennial. I say, yeah, this is a computer. Yeah. Should have been the other way around. The millennial saying, this is how you turn this on, right? Yeah. In any event, in the book outlines all the steps of going through the expectations. I'm not going to talk about all of them, but I'm going to call out 2 or 3. I will make this point just so you feel the gravity, and I think Bennett probably would nod in affirmation. There was a time that expectations I did just simply for ACGME rules, right? I thought it was one of those perfunctory things of just making sure everybody did it. Now I circle back and I realize that of all the things that I would do as a faculty development project, it would be this. Getting people on those shared same expectations. Case in point, a few months ago I got called in to salvage a program. They wanted 16 hours of faculty development. The program is on probation, about to be shut down. We spent the first day on this one slide. That important. And if you say, well, I don't have time to give expectations for my team, then I'd say back to you, you will not have time, if that's the issue, to fix all the problems that are about to come for not setting these expectations. But fair enough, you can read about it. The 3 that I want to call out, or the 2 right now, is number 1, delivering expectations as a group. Remember, the operative feature of culture is shared, that everybody has to have the same expectations of each other. And where you want to be given those expectations, everybody's sitting in the room so the students know the expectations of the intern knows the expectations of the resident knows the expectations of the attending, because when you're not around, you want that side-to-side enforcement. Remember, it's culture that governs behavior when no one's watching. But the second piece, as our bad student illustrated, is that all expectations need to come with rationale. And the reason being is that every student, every learner coming to you is not coming tabula rasa. They're coming loaded with all the expectations of all previous experiences they've had in clinical medicine. And when you bring your expectations, where they're likely to go is, oh, well, that's Wiese's style, right? But that's different than what the last attending did. The problem being is that if it's style, then it's subjective. And if it's subjective, it's unenforceable. The way that you beat it is by saying, listen, this is my expectation for you, and here's the reason for it. To give the person a chance of being able to rectify those differences in their experiences. So case in point, Jess, I need you to show up on time, 6:30 in the morning. Take personal sign-in from the night float. I know it's inconvenient, right? But if you're doing it by phone or picking up a card, you're not in a position to ask questions to the night float of what happened last night. Then we're not going to know what to do. Feel me on that? The rationale gives the expectation some gravity. Well, okay. This last one I'll hopefully get to as we get to the end of the talk. But I'm going to shift gears a little bit and talk about changing beliefs. Remember, knowledge, skills, and attitudes. And the attitudes is what you're after in making meaningful change. Well, where am I going with this? Okay, patient-centered rounds. Now, I'm going to be pragmatic. Any hospitalists in the crowd here? Yes, all right. Even outside of the hospital is good. Any of the supervising physicians in the crowd? The rest of you have seen them on TV? Okay. So I'm going to try to be pragmatic, because here's what I don't want to be. I don't want to be that educratic guy that comes to grand rounds and says, oh, you need to do it this way, you need to do it this way, right? Not accounting for the fact I've got to pull 4,000 RVUs, right? And my day's already stretched top to bottom. So I'm going to try to give some pragmatic advice on how to make patient-centered rounds meaningfully work. And what I'm talking about is not going at some point to see the patient with the team, but spending all of our time rounding at the bedside. But to make this work, the key piece is to begin with the lab spy, right? And if there's any great part of EPIC, it's this, right? In the old days, I'd have to sneak into the hospital and see patients ahead of time so my team didn't see them, and be dodging, running down staircases from 5th floor to 4th floor, right? Now, post-call, I wake up with my computer, have my coffee, sit down, and start going through all of their notes, right? Just to see what happened last night, right? It's a little spying on them. Now, there's a few reasons for this. One, pragmatically speaking, is that this helps me time manage, right? So if we only got 4 patients, or even if it's 8, but they're simple, then okay, attending rounds is going to be a lot of funny jokes and, cool personal anecdotes of how great I used to be, right? But if it's like 16 patients, then okay, we're going to be vertical, just stay to the point, right? Okay, fair enough. But number 2, what you're going to feel as I try to walk you through this, what you're going to see is that if we're interested in building the culture, changing the culture, getting people to think different ways, I've got to have some mental bandwidth to be focusing on different things. Put it this way, the jagged little pill, gone are the days of learning about the patients for the first time on rounds. If you are meaningfully interested in trying to change the culture of your microenvironment, you'll see it play out in a second. And number 3 is assessing severity of disease, because this would have been one of my meta lessons to the team. Now listen, when we round, I don't want to round on people chronologically, just who's in what room and what room and what room. No, I want to round according to severity of illness, right? So here's the standard. 3 Ds. I would like to see first, every day, the people that are dead or about to die. It's just really poor form to have somebody alive at the beginning of rounds and dead at the end of the rounds, and we didn't get to them. So those first, okay? Next, I want to see the discharges, right? Because the longer they stay, right? 15 minutes is 15 minutes where they could fall. So let's see them first, right? And then let's get them out. And then 3, I want to see the diagnostics, right? We'll see if we get that turkey in the oven early on Thanksgiving Day, right? So order the CT, the MRI. Maybe we get the results halfway through the day. We can act again, okay? So that'll be my lesson to them. Well, what I'm going to find in assessing their ability to do that skill, to identify sick versus not sick, is who they choose to round on, right? But I got to know ahead of time who's sick and who's not, best I can by that lab spy. So if we get to rounds, and sure enough, we're seeing somebody that's about to go to the ICU and somebody that's about to go home and somebody needs a CT, then I say, great, team learned the lesson, great. If, on the other hand, we get to rounds and it's like, oh, well, let's start with this guy. He's day 40 of his antibiotics for endocarditis that we can't get placed into a nursing home. I'm like, dude, no, you're missing the point, right? Like the guy that goes to McDonald's and orders the fish. Right? You missed the point, right? All right. But the fourth, and perhaps the most important, is that I get to choose teaching topics, you see, because I'll look through the notes, and they'll be like, oh, Felties. I don't know anything about Felties. Open browser, up to date, learn all about Felties. Yeah, then I'll get to teaching rounds, and they'll say, oh, yeah, it could be Felties. I'll say, I don't know anything about Felties. But here's what I do know. Blah! Right? And then they'll say, oh my God, how do you know so much? And that's for me to say, well, because I'm a doctor. Oh, all joking aside, the most important component of supervision, and for people that have done this for a long time, you feel this, but the most important component of the lab spy is this rule. The team can never see you doing their job. They can see you modeling parts of your job, of what they do, but they can't see you doing their job. If they do, there will come a day, and it is probably going to be Friday at 5, when they're saying, oh, you know, maybe I should run the labs on all our patients, make sure everything came back all right. But you know what? There's a happy hour I want to go to, right? So, and Wiese, yeah, he always runs the labs. He does my job, so I'm sure he'll be doing it, right? Spoiler alert, I'm at the happy hour. Yeah, and there it is, that ball halfway between second base and center field. They see you doing their job, they'll stop doing their job. And the other component, which we'll get to hopefully at the end of the hour, is that if you meaningfully want to get into wellness and burnout, I'm going to tell you it's not because we're yoga deficient. It's not. It's because people have lost purpose. They come to work and they're like, why am I here? Why am I doing this? If somebody else is doing this, this isn't changing anything. Mastery, autonomy, and purpose is what drives fulfillment. And burnout at the end is just work out of proportion to fulfillment. But an opportunity for them to have that autonomy. That's what I'm after, while still maintaining my fiduciary responsibility as supervising physician to make sure that we're not making the wrong mistakes. That is to say, supervision. Well, okay. Anybody read this book? Yes, it's his original. And on a different day, I'll tell you a story. I've actually had drinks with Malcolm Gladwell once, just by accident, which is fascinating. But this is still my favorite of Gladwell's books. And the story that I love is how they cleaned up New York City, right? So for people that haven't read the book, I'll make it real short. There was a time when New York City was going through a major crime wave, right? So lots of murders, rapes, burglaries, muggings, et cetera, et cetera. And so you would think, well, the way that you fix that is you come down and you go after those big things, right? And they tried that and it didn't work. But then they stumbled on something that did work. Anybody remember how they cleaned it up? Yep, they went after the people jumping the turnstiles in the subway, right? Now the thing was, so you jumped the turnstile, you didn't pay your fee, then they grab you, right? And they just handcuff you to a daisy chain of other people that were, being publicly humiliated. But what it communicated is, listen, these small crimes matter. You better believe the big crimes can matter. But why it worked was because it was frequent, accessible, and tangible. The 7 million people in New York City they were hearing about these murders, but they weren't personally feeling it. The 7 million people were seeing people getting arrested in the subways because they were accessing it every single day. What I'm submitting to you is that meta lesson number 3. Easier to act your way into new beliefs. And is there an opportunity in how we do rounds such that we could get people to act their way into that new belief? And to help me with this segment, audience participation, right, I have a ward team that has volunteered to come up, right? Yes, indeed. So come on up, ward team. We'll have you guys just stand over there for right now. And I need one person. Jeff, I think you would be perfect to be the patient. Yes? Yeah. All right. So let's have you lay down with your head that way. Yeah. Good. All right. Good. I would have had you, but I don't want to rip your shirt. So here we go. Yeah, I should have brought a pillow, actually. Our Prescani is going to take a hit on this one, I'm pretty sure. But all right, you guys do some ward things that you guys do. I'll talk to these guys here for a second. Here's what I'm talking about, right? You know the in and out standard, right? I'm sure you do this, being a high-quality institution that you are. So everybody hits the Purell before we go into the room, and everybody hits it when they come out, right? And you have those arguments with students of, oh, well, why do I have to use a Purell? I didn't do anything. I just stood in there. And you got to be prepared as the attending physician to say, well, listen, but nobody out here knows that. See, we don't know if you just stood in there and did nothing, or if you did the bare finger rectal. We don't know, right? So everybody coming out, so we can enforce it, has to hit the Purell. But here's the thing. You ready for this? If today there was a randomized controlled trial that said, hey, you know what, we got it wrong. The Purell thing, it doesn't really matter, right? You don't have to wash your hands anymore, okay? I would still make my team do it. Why? Because it's uncomfortable. And when I get that argument of, oh, I don't want to use Purell, it chaps my hands. Exactly. I want your hands to be chapped, right? I don't want, this one's out. Why do I have to walk all the way down there? Exactly. I want you to have to walk all the way down there. It's a moment of self-sacrifice. In our religious parlance as a metaphor, it's the equivalent, before we enter that sacred space, the patient's room, of doing the genuflex. A moment of uncomfort to remind you that once we cross that threshold into the room, this is not about you anymore. Right? When we come back out, it can be about you again. But when we're in there, it's not about you. So we're going to act our way into that new belief with a personal a moment of sacrifice, as ever small as it might be, right? Before we enter. Acting your way into a new belief. Well, okay. So here we are at the room. Now, I'm going to talk to my colleagues who are saying, you know what, I don't have time to spend doing rounds at the bedside. It's easier to card flip, right? I'm going to make the case to you that actually this will save you time in aggregate, but you got to do it the right way. First point is don't round twice, right? Where we come to the patient's room, right, outside in the hallway, the HIPAA non-compliant hallway, and we talk all about the patient, right? And then we go in the room and we do it again, right? My strategy is going to be going to the room, knocking on the door, and as I'm knocking, saying to the team, is there anything so super sensitive that we can't talk about it in front of the patient? But the combination, the timing of it is important, because I'm saying that as I'm knocking, which is conveying to the team. That's got to be a pretty high bar, because that's not our information, it's his. And I get it, right? You don't want to talk about how you could have cancer. But let me just tell you, right, having been a patient, the only thing worse than hearing people out in the hallway talking about how it could be, or hearing directly that it could be cancer, is hearing people out in the hallway talking about how it could be cancer, right? It's like going to an auto mechanic, right, where they open the hood of your car, and one guy's looking there, and he's like, oh, yeah, come over here, man. Right? And then another dude comes, and another dude comes, and you're like sweating bullets of, oh my God, just ching, cha-ching, cha-ching, right? And then they all break away. They're like, oh, no, just your gas cap was not fully on, right? Yeah. All right, so we're going to knock, and then we're going to come in. All right, come on in, team. So the choreography you see here is going to matter. And you've got 2 or 3 approaches. Come over here. The first of which I call the zoo approach, right? So, look at the patient in his natural environment. I wonder what he eats. Yeah. Oh, indeed. The second is the sidebar, right? Where we're all to the side of the patient, which is better. We're getting closer to the patient, but still, one of us is locked away in lines of sight, not being able to see the patient as we talk. All right? The best approach for choreography, think about it in your own style. This is the way that I do it. But I'll say, and this is where the introductions start to matter. And the first introduction as I come into the room, as I'm setting the choreography, is to say to the patient, hey, it's me, Dr. Wiese. You remember me? I'm the doctor that supervises your other doctors. That becomes important because the goal of this setting, what I'm going to try to build, you'll see it play out, is a bond between him and one of these physicians. What I don't want to do is rob that bond by taking it on myself. Because if I do, then this patient's not going to give him the information he needs later in the day to make the right decisions. I need these two to bond, and I can't step in the middle. I'm the doctor that supervises your other doctors. The next, as I'm setting the choreography, is going to be this. Each and every time that we see the patient, who is responsible for this patient? Got a problem. All right. All right. Who's responsible? Matthew? Yes? All right. Come over here, Matthew. Stand right there. at the head of the bed, right? And who's the resident? Scott, all right, stand right there, Scott. Good, right? Other person, stand right there. That's good. Sorry. Okay, well, here's why. I know what you're thinking. You're thinking, wow, my residents would never go where I told them to go. But they will, actually. If you just say, you stand there. See, they just go and do it. It's amazing. Yeah, all right. But here's why it's going to be important, right? Because what I'm trying to build are lines of sight. Now, I'm going to step back a little bit and tell you where I'm going to be. Because where I'm going to be is sitting down or kneeling down, right? For a couple reasons. One, because I'm personally going through somatopause, so it's just nice to sit down. I like that. But two, it gives me the perception of time, right? You guys stay for a second. I'll talk to them. Good studies on this, right, where they take teams and they say, hey, one team, here's what both teams, what we want you to do is go see your patients, spend exactly 10 minutes with all your patients. Okay? One team, you are to sit or to kneel. Other team, you are to stand. Then what they did is went back and asked the patients, how long were your doctors with you? You know what they found? Were the teams that stood the whole time. Guesses? Yeah, 2 minutes. That 10 minutes had contracted to 2. You see, what they see when you're standing there, right, is not only this creepy, like, ooh, right? What they see is not you standing. They see this, right? That you're about to bolt out of that room. And that's what's driving that loquacious patient with pressured speech. The fear of, I got to get all this out before you leave, which is what's costing you more time at the bedside, which is why most people, am I right, Matt, don't want around at the bedside for fear of getting caught in that vortex. Yeah. For the teams that sat or kneeled, how much do you think that people assess that time? Yeah, 20 minutes. It expanded. Yeah? Good call. You've seen this talk before. But continue to laugh at the jokes. Yeah, all right. So I'm going to sit or kneel. The other reason I like this is because from this vantage point, I've got a pretty good view of the room. You make a lot of diagnosis just from down here, right? Meaning, you see 10 bags of potato chips under the bed. You're like, well, call off that secondary hypertension workup. I think I found it, right? But the most important, again, is to establish lines of sight, you see. Because as this student is presenting, and as I'm listening to it, out of the corner of my eye, I'm watching this patient's brow, right? And or his pupils. So if suddenly the brow does what? Then that's my cue that something in that history that he acquired might not be fully right? And my time to say, is that right? You drink 48 beers? No? One 48-ounce beer? Okay. Same thing. All right. Back to you. All right. And if he happens to say the wrong thing, I'll be like, oh, it could be anthrax. Right? And then I see his pupils dilate, and that's my time to step in and say, no, don't worry about it. He just reads the Journal of Anderson Cooper. So you don't have anthrax. It's totally cool. If you did, I would not be in here. All right. Here's the point I want to make to you. All that information you're receiving from Matt out in the hallway, how confident are you that that information's right? We're making decisions on that information. All right? No better way to pressure test it than to have him stand right by that patient to present it. Now, I know what you're thinking. You're thinking, well, but this is going to cause a lot of stress for this learner, right? He's going to sweat. You're absolutely right. That's my way of moving him into that autonomy. And you say, well, this is against wellness, right? We're not being nice to our students. No. It's all going to be in a loving sort of way, but I'm giving him a chance to play. And the day's got to come, right? Eventually. But this is going to be a day that I protect. And what you'll find is that the patients actually are going to do you a big favor. This guy starts sweating, right? It's a nervous voice. You'll see the patient's hand come out. It's okay, baby. All right, Dave? You're all right. All right? The patient's got cancer and he's worried about this guy, right? No, but that's part of what I'm trying to build here, you understand, is the bond between these two. And part of what I want this patient to feel is the vast intellectual capital and emotional capital and how much this guy cares, enough that his voice trembles. But the patient can't feel that or see that if we're out in the hallway. And what I'm trying to set up is these two starting to build a relationship such that when I'm not around, that he trusts him. Yeah? Well, okay. Why is the resident over here? The second line of sight, because out of the corner of my eye, I'm watching this guy, right? So, and I'll pause for a moment and note that many of you in the audience do not have glasses, which is okay. But if you're going to be an attending, you have to have glasses. Right? So just buy ones with fake lenses, whatever, because you're just missing the opportunity to do the implied mental facepalm, right? This guy turns into a disaster. I'm just going to do the, yeah, which is my way of communicating to the resident, this is a mess to which heat has been applied, a hot mess, right? Fix this problem, right? It's my way of communicating. Remember, there's things you say and things that you communicate, but it's my way of communicating. He is your responsibility. You have stewardship over him, right? It's not his fault if he does a bad presentation. I need you to help him. With me? But the second line of sight I got over here is for a second reason, which is I'm watching what he's doing while he's presenting. Because he's doing one of two things. Either one, he's furiously writing all this stuff down, right? Which is my clue that he might have been a rock star intern. Totally cool. And eventually will be a great resident. But he's not there yet. Not used to managing other people's patients, right? He's behind his game. And that's okay. It just means that I'm going to have more supervision for him in the afternoon and making decisions early in the morning. Alternatively, he's standing over there mouthing the words like a parent at a fifth grade play. Giving the body English. That's somebody that's got his game down. He gets more autonomy. And understand this is a big part of the art of attending. Remember, mastery, autonomy, and purpose. If he deserves more autonomy, I got to give that to him. Right? That's how he grows. That's how he stays fulfilled. All right. Well, thank you so much, team. Good work. Yes. Good work. Thank you, Jeff. Being such a great patient. Oh, all right. The last thing I'm going to say in the assessment of that is what I'll call covalency. Right? That is, how tightly bound is the person responsible, the intern, and the patient? How tightly bound together are they? And there'll be a spectrum. You can try it out. Grab a random second-year medical student, take them to a patient's room, ask them to present. That will be inert, right? It will be as if the body wasn't even there. It's just about the disease. And then fast forward to your third year, maybe your fourth year students, maybe interns, where it'll turn ionic, right? Where they're connected, but only because the PK is right? They happen to be on their service, but after the fact, evenings, they don't really think about it. But you'll see eventually the covalency. That is to say, these two are sharing an electrode. And you'll know it when, as you're presenting at the bedside, or as they're discussing the bedside, you suddenly feel like the third wheel, right? Why am I here? These two start talking to each other. Well, we're going to change your beta blocker. What? Why are we doing it? Remember we talked about that? Oh, yeah. All right. You feel that covalency, then that person gets more autonomy. Why? Because if he doesn't know what to do, you know what? He'll find somebody that does. Because later on in the day, he's got an electron to lose in this thing. Yeah? Well, all right. Anybody read this book? No? It's not super great. I just love the concept. Right? Schwartz's book. Schwartz makes this case, right, that people love choice. And the reason that they love choice is it gives them a sense of empowerment over their environment, right? Anybody here have, like, 1-year-old kids? Any rest of you seen kids on TV? Know what they look like? Yeah. So you know what I'm talking about is that after they leave the bottle and you finally got them into the high chair for their first meal, right? And you put in some oatmeal and put all your work on it, and you're just so super confident they're just going to eat it. But what does that toddler do? Maybe it was just my toddler. I don't know. Just takes that oatmeal and just throws it on the floor, right? And if you're like me, you're like, dude, why'd you do that, right? Now you're just out some oatmeal. I mean, but my daughter loved it, right? Just was laughing hysterically. Why? Because she loved the idea that she could control something in her environment. It's that primal. And having a choice gives you that sense of control. Now, there's something I'm going to be doing behind the scenes that the team doesn't know about. That's why I asked them to sit down, because I don't want them to hear this, right? But I'm going to do it. I'm not going to say I'm doing it, but by the end of the month, they'll feel it, and they won't even know that they've changed in the way of this new belief, which is the new belief of empowering the patient with choice. Because here's the thing. I don't know if you've ever been a patient. Again, I have. And I can tell you the most frustrating part about being a patient is losing all control over your environment. Where I used to be hungry, I'd just go to the refrigerator. I can't do that anymore. I got to go to the bathroom. I'll just go to the bathroom. No, got to call a nurse. It's debilitating. But you can give back that choice, even if it's only in a semblance of choice. So 5 times with each patient, the team won't even know that I'm doing it. But 5 times while we're in the room, I'm going to be asking innocuous choices. Do you want this curtain pulled open or back? Do you want the TV on? Do you want the TV off? Do you want to watch Price is Right? Seriously, could you not watch something other than Price is Right? Right? Yeah. 5 innocuous choices. Right? And what you'll find by the end of the month is that it'll seep into them. And by the end of the month, you'll find residents saying, all right, we got a choice. Beta blocker or ACE inhibitor, which do you want to do, patient? Right? All right. Something to think about. Well, all right. We're out in the hallway. And an opportunity for this. Anybody recognize this? Coming to America, yes, indeed, which most of you didn't get, so I'll tell you it's a very, very funny movie. And it reminds me of another story. Several years ago, senior physicians, you might nod in affirmation if you've experienced this. Several years ago, I was attending, and it was June, and it was funny, right? Everybody was having a good time. I had great jokes. And then it was just 1 calendar month later, in July, I was attending again, and suddenly I was not funny. I was like, what happened? Did I have a funny stroke? Right? I have lost my funny. Yeah? And then it dawned on me that everybody in the team was not getting my cultural references. Right? So I came home demoralized. All right? I told my wife, I was like, you got to help me. Right? And teach me about the culture of the youth. Right? So I can learn what's funny, what movies, and all that. And she's good at that. She listens to NPR and all that business. So she knows culture. And so she gave me a list. I watched all the movies, right? And I had a whole new set of jokes. And so I come back. And the problem was they were just almost there, right? Just enough where I'd get exactly that. Jeff's give me that polite, like, ha-ha. Almost funny, Wiese. Almost. I was like, man, what am I going to do, right? And then it dawned on me, you know what? I'm the attending here, and the program director for that matter. So here's now what I do. During those set of expectations, I say to the team, listen, I'm going to give you a list of movies. You don't have to watch these movies, but if you do, I'm going to be a lot funnier. All right? So here you go. All right? Watch these movies. All right. Well, not to spend a lot of time on this, but I do want to touch on what McDonald's figured out a long time ago, which was closed-loop communication. And if you've been through a drive-thru, you know what I'm talking about. Right? You put in your order, hey, I want 2 Big Macs and 3 shakes, and don't judge me, I'm American. Right? So, and then what you get back is, oh, you want 3 Big Macs and 2 shakes? No, I want 2 Big Macs and 3 shakes. Okay, 2 Big Macs, 3 shakes. Right? It's say it, and then have the person confirm it, right? And then edit or assure that that was the right communication. Get it? Got it? Good. Yeah? It's safety in communication. Now here's what we could do as a program director. It's what I tried to do starting out. Is we could have a whole module on closed-loop communication for sign-out at the end of the day, right? A whole curriculum on it. But it's not a what of thinking. It's a how of thinking. Does this matter that much to you? Could you, right, get people to act their way into that new belief that just because you said it doesn't mean that it counts, right? That I got to make sure that somebody understood it. And the way that you do it, and the way that I do it, is every time as we come out of the room, then I'll say to the team, all right, based upon what I heard from you, here's going to be the plan. We're going to order the echo. We're going to call cardiology. We're going to increase the Lasix. Now repeat that back to me. Do it every single time. And you feel this, right? That there's 15, maybe 20 times during the day you have the opportunity to get people to act their way into that belief. And what you'll find is at the end of the month, right, they'll bust you on it. Where the resident's like, hey, you know, I'm going to call pulmonary. We're going to order a CT. All right, sounds good. No. Repeat back to me. All right, you're being annoying, but you learned the lesson. That's good. All right. Fast forward to feedback. Maybe this will be the last thing we'll see. But okay, before we get into feedback, we got to step it all the way back, because now what I want to take on is the shared roles. Yes, indeed. Anybody read this book? Of course not. Nope. This was a book written in the 70s, 80s maybe, by one James Carse, a religion professor at NYU. Promptly got lost because it was just way too much. People are just like, whoa, slowly back away. Now, I see people taking pictures of this, right? So now, just for this minute, I need you to look at me eye to eye. With me? Because I'm not going to be morally responsible for this. If you read this book, you are to make no major life decisions. Okay? Don't buy a new house, buy a new car, get a new spouse. Because while reading this book, I promise you, this book will mess you up. And I don't mean kinda. I mean, you're going to be rocking in the corner listening to Coldplay eating porridge. That kind of messed up. Yeah? But here's where Karas goes with this book. He says that when people interact with each other, they enter one of two types of games. Right? And I'll walk you through it. Finite games, which to help you understand as a metaphor, maybe think of a football game. Okay? Finite game has a finite beginning and a finite end. All right? In a finite game, people are playing roles. They're not actually themselves. They're abstractions. Case in point, if you go to a Broadway show, another example of a finite game, then Miranda is not actually Hamilton. He's not. He's just playing the role of Hamilton. Right? You go to Aaron Rodgers' house and you knock on the door, right? He's not going to open the door wearing shoulder pads and a helmet. No, he's just playing the role of quarterback during the finite game, during the day. With me? Yes, indeed. In a finite game, the goal is simply to win the game. That's it. And the utility of any action in a finite game is measured solely by whether it helps you win the game. If it doesn't, there is no utility to that action. A running back in a football team that likes to do a lot of dancing around, that's great, but it's not helping us score touchdowns. You get traded, right? In a finite game, important for us is that what is not explicitly prohibited is implicitly allowed. For anybody in the patient safety quality workspace, that's called a workaround. Didn't tell me I couldn't do it, then I can do it. You say, well, that didn't happen in medicine. Really? Let me take you back to time to antibiotics. Remember that debacle? If you don't, for the younger folks, it was a decision that, hey, people with pneumonia, if they got antibiotics within the first 4 hours, they did better. So we'll grade hospitals on a quarterly basis, defined beginning and a defined end, right? And hospitals that, patients that got those antibiotics in 4 hours, they're green, good hospitals. And hospitals that didn't, bad, red hospitals. So what did the hospitals do? What did we do? We gave everybody antibiotics, right? Even people walking in front of the ER, here's some antibiotics. Right? And we won the game. What is not explicitly prohibited is implicitly allowed. All right. Compare contrast to an infant game. Maybe the best way to explain an infant game is to take you back to grade school. And you remember those days? Yeah, after school, playing with your buddies, right? I don't know what game might have been touch football or basketball or kick the can or whatever. Remember that? Yeah? And in those days, you'd have two teams of kids, right, playing, and one team would start to win, really win. And what did the kids do? They changed the rules, right? Like, they'll switch quarterbacks, right? Or, hey, new rule. If you throw the basketball, it goes off the garage and then in, you get 36 points. Right? And everybody stops, allows that to happen, because the singular goal for those kids is to just push the sun back up into the sky for one more hour before mom calls us home for dinner. Play as long as you can play. Now you tell me, thinking about where you're at in that vision, doesn't that make you happy? Does me. Then you say to yourself, wow, where'd those days go? Middle school. That's where they went. Because know this about any infinite play for play's sake, which you can really boil down to in infinite play, it's the people, not the roles, and that the goal of playing is innate, just to play, whatever the activity is. But whenever you put stakes on an infinite play and you measure it, now it morphs into a finite game. Like a core metric, right? Indeed. And in middle school, we stopped giving you S's for satisfactory. We gave you A's, right? Yeah, and now the stakes increased. Yep, and indeed. these examples started to become the socialization, and this is where it's going to mess you up, as it did me, because I have been socialized into being a finite thinker, as will be the people that you are trying to coach and teach. We have socialized them through high school, that you have to get A's to get into the best colleges, right? And in colleges, we built out semesters, finite beginnings, finite ends, right? And the goal in that semester was to get the A, right? Yeah, don't lie to me. Go back to that course in college. You know the one where you racked up enough points halfway through the semester that regardless of what you did on the final, you were going to get an A? What'd you do? Yeah, you just took a knee, right? Nah, I'm not going to that class anymore. It's done. Yeah. And then you go to med school, where the goal of the clerkship is to get the honors, right? And then into residency, into shifts. Here's the thing I'm submitting to you. These people coming to you, they're not just good finite game players. They are the ninjas of finite game play. Yeah, and you say, well, that's not true, right? All right. This is why finite game might make you unhappy. Tell me you haven't heard this. Hey, is this going to be on the exam? Because implicit in that question is that if it's not going to be on the exam, I'm not going to learn it, right? Learning for learning's sake would be infinite play. You never know where you might need that knowledge down the road. But learning for the exam is finite play. Yeah? Utility of any action, right? Measured solely by whether it helps you win the game or not. Why are your medical students always leaving early in the afternoon? It's because they figured it out. You can weight your evaluations however you want, right? 90% of the grade is on the evals. Well, all right. Welcome to Lake Wobegon, because everybody's at 8 or 9 out of 10. And they figured out the only way to stratify who gets honors, who gets high pass, is the shelf exam. So now it governs their behavior such that they go to the coffee house instead of being with the patients, which would have been infinite play, right? Years down the road probably would have benefited them. But in the game that they're in, they're at the coffee house trying to win that shelf. Doesn't make them bad people. It's just the way that they've been socialized to think. All right. Hey, why are people like Jeff there, right? I know Jeff's not checked out. No, he's already got his EP fellowship. But why are your third-year residents checked out in the spring? You say, well, it's because they're burnout. They're not burnout. Find them in July, right? When they're in the fellowship. Now they're excited again. It's because their finite game's over. The match was in December, right? Now it's done. They get a 2-touchdown lead, and I'm just running out the clock, right? Yes, indeed. Now, lest you think, and Dr. Page is getting worried. He's like, whoa, I like these finite games. It helps my faculty actually get promoted. And you're right. You have to win your finite games. If you don't win your finite games, you cease to play. Nothing wrong with finite games. It's just that when finite games compromise the infinite game, that's where it becomes a problem. And so the last thing I'll leave you with is there a way of getting people to act their way into a new belief of thinking infinitely, right? Which is what I call feedback. And 2 opportunities, a couple things to throw out. One, I'll start with mid-month, right? So after a couple weeks. And the student's going to come to me and say, hey, can I get some feedback? Okay, and I'll translate that for you. Hey, am I going to get honors? Right? Okay. So I could address that, or I could take them just a completely different way. And what I'll say to the students is, here's what I'm going to do. I'm going to write out 10 things in this piece of paper. 10 things that I think are competencies that would, be good for your performance at your level. And I want you to take a penny. I'll give you one. I know you're short of cash. And I want you to put that penny on your weakest area. And I'm going to have a penny, and I'm going to put it on what I think your weakest area is. And we're going to spend our time talking about how we improve those things. Yeah? You see implicit in that, what I'm doing is, one, completely dodging the whole discussion of whether you're winning a finite game or not. Okay? And 2, I'm thinking by getting them to think into that infinite play, which is an infinite way of thinking, that however good you are, you could be better. And it's what that I want them to learn. I'm doing it for you here now. But later on, I want you to be able to do this yourself. Always looking for the weakest area and how to improve it. Yeah? All right. So the last piece is begin with the end in mind. And I told you that this is where we would land, and this will be the last thing I take you through. Anybody seen this? The Johari Square. Yeah, I'll walk you through it real quick. There are things that you know about yourself. Okay? There are things that you don't know about yourself. There are things that other people know about you, your public life. And there are things that other people don't know about you, your private life. Right? Okay. Here's what I'm going to do on that first day of expectations. I'm going to say to the team, here's how it's all going to end, guys. When this is all done, we're all going to sit in a room, and I'm going to dismiss you one at a time, and we're all going to talk about you. Things that you did well and how you could improve. Then you'll come back, and I'll dismiss somebody else, and then I'll even leave the room, and you can do it. And then we'll all sit in a room, and I'm going to go person by person and say, hey, what do you think of chess? And everybody can go around the room, and what they don't feel comfortable sharing, then I'm the attending. I'll take the tough road, and I'll share what they said. So here's the thing. You could go about this award month of doing what's best for you, winning your finite games, and throwing your buddy under the bus. But I might think twice about that. Because at the end of the day, it won't be me giving you the grade. It's going to be your buddies. Here's what I'm trying to get them to act their way into. Right? One is to see it from the beginning, that you are your brother and sister's keeper. That's a new belief for a lot of the people that we teach. They've all been about number one. How do I get ahead? Right? How do I get the best residency? That's fellowship. But to act their way into, I have stewardship obligation for this person next to me. And to act their way into it by asking them to give feedback to each other. That's what I'm after. But the benefit is twofold, and I'll submit this to you, that the reason that we might not be good at giving feedback is because nobody ever taught us how to give feedback. And it's my chance to teach them by acting their way into it, right? Not only to receive feedback so that their blind spot closes, but to give feedback. Because as you give feedback, you are saying something about yourself, something you might not even know about yourself. But what you choose to give people feedback on is giving you a clue as to what you value. If I say, hey, you got to work better with the nurses, respect them. What I'm really saying is implicitly, I value nurses. I value that we should respect them the way we do anybody in the healthcare team. That might be something I was aware of, might not. Point being is that as you do both, then that unknown square starts to shrink. Well, all right. I'm going to end by this last piece and simply say, I'll tell you this last story. It's real short. Anybody know the name Don Abedian? A couple nods. Yes. All right. So you might say it was, I think it'd be a fair argument, the godfather of quality. It really was. 50 years of quality patient safety. Don Abedian's the one. He was at the University of Michigan, but he introduced the idea of process measures in addition to outcome measures, right? And systems measures, right? And in some ways, if you're feeling that finite game, it was his way of making sure that we were doing the infinite play and just not trying to get to time to antibiotics. Yeah? But at the end of his life, on his deathbed, they ask him, Don Abedian, what's the secret to quality? You know what he said? And they were fully expecting, measurement and data, RCAs, PDSA. No. What he said was one word. He said the secret to quality is love. Love. That visceral love that somebody would have for their system. This is my house. I own it. I don't rent it. And if there's problems with it, I'll fix it. And I love the people that I work with, and I want to make them better too. If you found an institution full of love, that would eventually become highest quality. What I'm going to flip around to you is that we can do all these great things as supervising attendings and great teachers. You can become really good if you do all those things, but you can't be great. The space between good and great, being a supervising physician, being a teacher, is that same one word, love. Do you viscerally love your students, your interns, people you have stewardship over? Do you have that love? And if you do, you have a shot at being great. And if you don't, you can be good, but you can't be great. Now I see in your eyes, you're like, yeah, it's just one problem. I don't love my students. I hate my students. Right? Sometimes I look around for a rock to throw at my students. And that may be right. But I'll end with that central tenet, right? Meta lesson number 3. And it's a short story of somebody that went to Dale Carnegie after his talks. And the person said to Dale Carnegie, hey, I got a problem. I don't love my wife anymore. What do I do? Dale Carnegie said to him, here's what you do. You go home. And you do everything consistent with somebody that did love their wife. And you do it again and again and again. And then you'll find one day that now you do again love your wife. You will act your way into that new belief. And I'll be honest with you, there are times that I do not love my students. But I act my way into that belief. Doing everything consistent with somebody that did. And almost always, at the end of that month, I find myself in that space. Doesn't make me great, but it at least gives me a shot to be there, huh? Well, regardless of what you thought of the talk, I think we will agree that this definitely was not what you thought, right? It's been a pleasure.
Jeff, that was nothing short of an outstanding talk. I wish we had more time. We're going to have to close it there. I do want to thank you. I want to thank Jess for identifying you as our dream speaker and present you with this plaque, which is signed by myself and the 4 chief residents. And thank you again for visiting with us today.
Thank you.